Welcome to this webinar reporting on the findings of a scoping review of NHS Use of Force policies and their implementation of the Cheney's Law requirements for people with learning disabilities. I'm Dr. Beverly Samways. I'm an associate researcher with the University of Bristol and the founder director of Unique Connections, which is a self-injury specialist organisation supporting people with learning disabilities. Before I get started, I just need to acknowledge those who contributed and supported the project. So the original research was funded by the Baillie Thomas Charitable Fund, and some of the later impact work was funded by a seed corn award from the Impact Accelerator Fund, which is run by the Economic and Social Research Council. So we're grateful for that. It was done in partnership with the University of Bristol. And then we had these two organisational partners, Unique Connections, for which I spend some of my time working, and then also Restraint Reduction Network, which is highly invested in this space. So we also had a really wonderful team behind us. So I was leading the project with the support of Dr. Lucy Series, who's an experienced researcher in this field at the University of Bristol. And then we had a wonderful advisory board backing and supporting the work and also the impact of the work. So that included Baroness Sheila Hollins, who is a well-known peer and also a learning disability psychiatrist. We also had Professor Chris Hatton on the team from MMU, who is an expert in learning disabilities and the law. We had Alex Ruck-Keene, who is a KC in this field, and Ben Higgins, who is the CEO of Restraint Reduction Network. Just wanted to express our gratitude to this team of people who have supported the research and continue to track it with us. So this research was all about the Mental Health Unit's Use of Force Act 2018 and its accompanying statutory guidance. So a little introduction to that legislation before we go on. So this piece of legislation seeks to reduce the excessive and disproportionate use of restrictive practices in mental health care settings. It's often known as Cheney's Law because the Act was introduced in response to the death of Oleshani Lewis. So Cheney, as he was known, had voluntarily admitted himself to Bethlehem Royal Hospital after developing symptoms of psychosis. He had become unsettled and wanted to leave, but was prevented from doing so, and then resisted the hospital staff's attempts to take him to a seclusion room, and so the police were called. Cheney was subsequently restrained by 11 staff and police officers and died of a cardiac arrest. The jury at his inquest described this restraint as prolonged, disproportionate and unreasonable, and the coroner attributed this to poor training, poor communication and lack of required reading on restraint and its dangers. So this Act, the Mental Health Unit's Use of Force Act 2018, known as Cheney's Law, is the result of a tireless campaign for justice led by his mother, Ajibola Lewis. So in terms of people with learning disabilities, Cheney's Law requires mental health wards to take steps to reduce and prevent disproportionate or inappropriate restraint. Each trust must appoint a responsible person to create a use of force policy that meets particular requirements, such as involving patients and families, publishing it online, making it accessible, and so on. So the statutory guidance notes that some patients face a higher risk of experiencing a disproportionate use of force. So as a young Black man, Oleshani Lewis was at higher than average risk of detention under the Mental Health Act and twice as likely to experience restrictive practices in hospital than white patients. And so this research examined the application of Cheney's Law for another group of people who were at heightened risk of prolonged mental health detention and the use of force, and that is people with learning disabilities. And the Act specifically addressed this marginalised group as well. So a little bit of background to why people with learning disabilities was a focus for this research. So following the Winterbourne View abuse scandal in 2010, successive policy initiatives have tried and failed to reduce the number of people with learning disabilities and autism in mental health wards. So there's currently over 2,000 people with learning disabilities and autism detained on mental health wards, with almost 60% of those having been in hospital for over 2 years. A survey in 2020 found that 81% of the 313 wards accommodating people with learning disabilities and autistic people had used physical restraint in the previous month, and almost 18% had used prone restraint, that is, being restrained on the floor face down, which presents risks of injury and death. So hospital environments often fail to meet the needs of individuals with learning disabilities. And this is often because staff lack appropriate training and resources, and comprehensive assessment, treatment and discharge planning are frequently absent. These circumstances elevate the likelihood of restraint, seclusion and segregation, experiences that can be especially traumatic for this population. So the persistence of these issues has kept them at the centre of policy debate, with growing calls for effective action. So Cheney's law and the accompanying statutory guidance acknowledge the challenges and mandate that each mental health unit explicitly considers the needs of individuals with learning disabilities within their use of force policy. So having thought a little bit about the background, let's move on to think about the research, the scoping review study, what it was seeking to achieve, aims and objectives and methods and so on. So the research asked, to what extent are the restraint policies collated from the scoping review implementing the requirements of Cheney's law, with particular respect to the needs of people with learning disabilities and their co-production in producing policies. So our aims and objectives were to synthesize the contents of the current restraint policies used in mental health wards, and also to draw from the expert knowledge of our advisory board to identify, we were hoping, examples of good practice and develop guidance for mental health wards to use to improve the quality of their policies. In July 2023, we made a Freedom of Information request asking 51 NHS Trusts in England for their use of force or equivalent policies in accordance with the requirements of Cheney's law. Three trusts reported that they had no inpatient services for people with learning disabilities and were not supporting people with learning disabilities in wards. And that was confirmed as best we could through websites and reported data, leading to their exclusion from the study. So we ended up with policies from 48 trusts. So as the research continued and we did some additional research in January 2025, we gathered those policies from 2023, we reviewed them for currency, and as necessary, we either updated versions by downloading the latest one from the Trust website, or we followed up with a new Freedom of Information request for their current policy. In that Freedom of Information request in January 2025, we also asked trusts to send us any adaptations of information relating to Cheney's law for people with learning disabilities. We noted that we were particularly interested in sourcing good practice in how people with learning disabilities are supported when they come into NHS mental health wards. So information on the use of force for patients was collated from the responses received, and it was also supplemented by searching trust websites, and that resulted in patient information about Cheney's law collected from 34 trusts. So the analysis and presentation of that information is captured in a second report. So if I say briefly something about data analysis, this was relatively straightforward. We analysed the policies quantitatively, so we took the basic requirements from Cheney's law pertaining to people with learning disabilities, and we assessed, does the policy include this information? Yes, no, or almost. So using a tertiary scale or a RAG rating. We looked at a qualitative thematic analysis using NVivo, where we analysed the extent to which the more like qualitative and subjective requirements, so not just does a policy include information about this, but how is the quality of the information. So I'm presenting today the results under 10 different inquiries, which we'll go through systematically today. So let me say something about the publishing of policies. So Cheney's law is very clear that the policy on the use of force must be published on the Trust website. So we did a straightforward analysis, which trusts of the 48 did have their use of force policy or equivalent on their website. We found that 28 did, so 20 did not. We've also found that some they might not have their policy on the website, but they might have some patient-facing information on the website. So overall, we found that there was 13 trusts that had no information on their website at all that was publicly available about the use of force. So no policy and no patient-facing information. And so because this is to do with patients' rights and having accessibility to the things that they might that they need by law. And we did intervene on this one. We emailed the relevant trusts, drawing to their attention the requirement to have their use of force policy on their website. And a small number responded saying that they had done this or were working towards it. So our first recommendation is real straightforward: publish the use of force policy on the Trust website. So the second thing we looked at is the policy reviewed in accordance with the guidance and the recommendations? So Cheney's law says that it should be done annually, which obviously gives some room. That's their recommendation. And what we found was that 30 policies were being reviewed 3 yearly, or at least that was the plan. Just 5 were compliant with the recommendation that they should be reviewed annually. So not in line with the recommendations, but this is a should, not a must. We do think with the importance of this policy that there should be an annual review. Again, we intervened on this particular issue and we emailed the trusts that had either provided us with an out-of-date policy or had published an out-of-date policy on their website. And again, we had a few replies confirming that they had renewed or changed the policy on that was available online. So our second recommendation, again, straightforward: review the use of force policy annually and keep it up to date. So thirdly, Cheney's law requires that policies make 2 basic commitments. One is a commitment to the minimisation of the use of force, which we'll think about on 2 levels. Firstly, the commitment to the minimisation of force, and then to what extent that is specifically extended to thinking about people with learning disabilities, because the law also talks about considering the minimisation of the use of force for those with protected characteristics. And then secondly, the policy's commitment to protect or uphold human rights and freedoms. So if we start with the extent to which policies made a commitment to the minimisation of the use of force, well, it would be difficult to write a use of force policy that didn't mention this at all. So of course we found that all the policies made some kind of commitment. However, we did also find that 36 policies made what we would consider to be a straightforward commitment. They just said, we are committed to this. But 12 policies made a qualified or a mitigated statement. So some of them were just simply very vague. Some of them were mitigated. So they would say, we will do this, but, and some of them conflated this statement with other concerns. So on the screen, you can see that there's some examples of like strong commitments. So the first one, the Trust makes a commitment to restraint reduction program using person-centered trauma-informed care. You can see that the language is deliberate and definite. And then we had examples like the 2 below, where it says physical intervention should be avoided if at all possible. It feels important that when you're making a commitment, you just make it in a straightforward way, rather than either explaining that there might be times when you don't need to, or using the sort of passive language of should rather than must or we will. And then we had some policies that conflated this idea of restraint with the idea of patient violence, so often using the language of violence and aggression to describe patient distress. So the one on the screen says the policy's objective is to guide short-term management and long-term reduction of violence and aggression. This will be achieved by an overarching restrictive intervention reduction strategy. So you've got these two ideas of the staff using restraint or using restrictive intervention, that being the language for that. And then what is happening with the patients is called violence and aggression. So, this statement from the example trust assumes that restrictive practices result from patient distress, as we would call it, but as many of the policies use the language patient violence. And this suggests or assumes that the way to reduce restrictive practice is only by reducing incidents from patients. So the patient is the cause and the restraint is the result. And that means that some of those commitments in the policies that were based on that assumption were really commitments that were built on the assumption that minimizing restraint is actually a commitment to reducing patient incidents or violence and aggression, as it was so often called. So this conflates restraint reduction with incident reduction, and it implies that the responsibility for reducing restraints is with patients. This was a wider finding in the language of the policies. So to illustrate, 13 trusts responded to the Freedom of Information request for their use of force policy by sending a policy entitled Prevention and Management of Violence and Aggression. Into each of these was an attempt to incorporate the requirements of Cheney's law, but it's problematic, isn't it, couching restraint reduction strategies under a policy entitled Prevention and Management of Violence and Aggression. It communicates something wider about how the use of force is understood and perceived. So there was an underlying sense in some policies that reducing restraint was primarily conceived of as something contingent on reducing incidents of distress first. But this act itself is called Cheney's law to remind us that the relationship between patient distress and staff restraint is not linear. It's not one causing the other, but rather it is bidirectional, and it's complex, one leading to the other and back again. It is a requirement for trusts to implement plans to reduce restraint that are not contingent on a prior reduction in incidents. This is led by the evidence base that confirms that whilst patient distress might be understood to necessitate a restraint, it's also true that the patients witnessing restraint, having a fear of restraint, and the experience of being restrained can all cause significant patient distress. Thus, the relationship between incidents or distress and restraint is codependent rather than linear. And so it was notable to us that there was this linear understanding about patient incidents and that led to or caused or made restraint unavoidable. So we also thought about to what extent did trusts consider the minimisation of force specifically in relation to people with learning disabilities and related reasonable adjustments. And we found that just 5 policies acknowledged the heightened risks of trauma, distress, and restrictive interventions for people with learning disabilities, whilst none of them suggested specific ways to minimise that force. There's some examples on the screen, but in short, there were no exemplar commitments to minimising the use of force against those with learning disabilities across the 48 policies. So our third recommendation is that policy should state a commitment to minimise the use of force, which is active, not passive, that is unmitigated, unconflated with incidents, and makes reasonable adjustments or considers the needs of people with learning disabilities. Cheney's law also asks policies to make a clear commitment to upholding and respecting human rights of the patients. So we found that all policies except one mentioned human rights, and 31 policies, or 65%, made a straightforward commitment to human rights, such as the example given: all uses of force must be rights respecting, lawful, and compliant with the Human Rights Act. We found that 11 policies used the language of legal compliance, so we must comply with this, rather than actually making a sort of commitment that sounded like it was a cultural commitment or an expectation of the trust. And we had 5 policies who mitigated their commitment. One trust did not mention human rights at all in the policy, but they did mention it in their patient information, but they did so with mitigated language. So that's the example on the bottom left of the screen. So they said, we recognise the potentially traumatising impact the use of force can have and the human rights implications of such interventions. However, we also recognise that this has to be balanced against our duty to protect patients. There's something about immediately following the statement that commits to something with a statement that mitigates or detracts from it, that implies that the commitment is not full. So our fourth recommendation is to state the Trust's unmitigated commitment to, rather than compliance with, human rights. So the fifth element that we looked at was the co-production of policies and the co-production or consultation on the review of policies. So Cheney's law requires that policy and major amendments are consulted on and co-produced with a range of groups, including current and former patients and disabled people. Section 4 recommends that the Trust details how the organisation or trust will work to co-produce policies and information with their local patient populations. So we can see from the slide that the majority of policies were co-produced, but there was also more than a third of policies that made no mention at all of co-production. And then the level of commitment to co-production again varied. So we had some very active commitments that said, and this policy was developed under consultation or co-production, as we can see at the top, and also explaining who they consulted with so that it's all clear. And then we had some other policies that made really ambiguous statements. So the one on the right-hand side at the bottom of the slide reads, the responsible person must publish details on how organisations will work to co-produce policies and information with their local patient populations. What's unclear from this statement is that the policy is recognising that this must happen, but in no way is it saying whether it has happened or not, or if it has happened, who was consulted with. So it's an acknowledgement of the requirements of Cheney's law without stating whether they have met it or not. And we could find no evidence that there had been any consultation with local patient populations. In short, 22 trusts mentioned co-production of their policies. 14 of these stated they consulted with patients on a review of policies, but not all of these produced a candid commitment stating who they had consulted, as we can see from some of the examples. So our fifth recommendation is not to just state that a policy should be co-produced, but to say that it has been, and to state the range of groups that have been consulted with. It's one thing to say that you have consulted, it's another to say who with, and how that has happened. So sixthly, we looked at whether the policies considered the needs of people with learning disabilities based on the Section 3 requirement that says that it is essential that policies reflect the need of patient populations using these services, for example, patients with autism or learning disabilities. So overall, we found that 37 of the 48 policies made some reference to people with learning disabilities in their use of force, although the way in which they considered the experiences of people with learning disabilities varied considerably. We found that 8 policies made incidental references to people with learning disabilities, for instance, in stating the scope of their policy or mentioning an organisation or legislation that contained the term learning disability, so very, very incidental. And 3 trusts made no mention at all, and I'll come back to those in a moment. So those that did consider reasonable adjustments for people with learning disabilities tended to consider sensory needs in a relatively superficial manner, as the example on the screen shows, which was certainly one of the better ones, but is still thinking in relatively basic terms. Of the three trusts that made no mention of people with learning disabilities, we looked at the NHS data set for these three trusts to see to what extent they were currently supporting people with learning disabilities in their mental health wards. And the report that's online covers this more fully, but just to say that overall 16 patients with a learning disability or autism were receiving care in these three trusts altogether. And we looked at the figures for April 2025, and there had been a good number of restraints on those patients in that time. So the fact that these trusts had produced policies that made absolutely no mention of people with learning disabilities or related reasonable adjustments represents non-compliance with the essential requirement to ensure that policies reflect the needs of the patients for which they are providing care. Our sixth recommendation is to specify how you are making reasonable adjustments for people with learning disabilities, and of course to make sure that you are considering them in the policy if you are providing inpatient services for people with a learning disability. Seventhly, we looked at to what extent the policies talked about or explained how they would involve patients in care plans. That was based on the Section 3 requirement that states that a policy should detail how patients, their families, carers, and independent advocates will be involved in care planning, including setting out preventive strategies to the use of force, for example, through advance statements, and as a way to take the wishes and preferences of the patient into account. So we found that 92% of trusts mentioned that patients would be involved or included in care planning, either in their use of force policy, their patient leaflet, whether it was easy read or not, or both. We found that 81%, so 39 out of 48, mentioned advance statements or wishes. So we had 4 policies that made no mention of collaboration in care planning, whether in their main policy or patient-facing information. Once again, the wording really varied from passive language, which talked about that there needs to be or there should be something, which again doesn't make loads of sense in a policy document that should be setting out a trust's practice. And then there was some far more active statements talking about that the patient's wishes and preferences must be taken into account, which much more reflects Shoney's law guidance, and that it was essential that they were included and involved in their care planning. We did think about to what extent patients with learning disabilities were involved or included in care planning, and we found just 4 trusts that made a mention of this. There's an example on the screen, which is probably the best of the 4, but ultimately we found that there was no exemplar examples of policies making reasonable adjustments for the inclusion of people with learning disabilities in care planning. So our 7th recommendation is to state how all patients, including those with learning disabilities, will be involved in writing their own care plans. If we turn our attention now to debriefs, drawing on the guidance that says that use of force policies should detail how patients, families, carers, and independent advocates will be involved in post-incident reviews following the use of force, and how the impact of those incidents will be reflected in the patient's follow-up care. So we found that all but 2 trusts mentioned post-incident review or debrief in some capacity, either in their use of force or in another policy. And we found that 2 trusts did not mention debriefs in their policy at all. One of those trusts did discuss it comprehensively in another policy, but there was one trust that we found that had made no mention of debrief or post-incident review in any context in their use of force policy, couldn't find evidence of it in another policy, and they had not provided a patient or easy read version. We did look at the NHS data set around that trust, and found that in April 2025, they're detaining 40 patients with a learning disability and or autism in a mental health ward, and 15 of those patients had been restrained a collective 50 times. And so there's some concern that there would be no provision made in the use of force policy for the use of debrief, and no patient or easy read version that might equip someone with a learning disability to understand their rights. We also looked specifically at whether the policy considered people with learning disabilities in relation to debrief. And you can see from the pie chart on the right that 13 made some consideration or talked about different communication styles or some kind of nod in that direction. We found that 8 trusts didn't consider people with learning disabilities in debriefs in their policies, but had somewhere else, like in their easy read. But we found that the majority of trusts, 54%, had made no mention of debriefs with people with learning disabilities or any accommodation for different forms of communication. We then moved on to a qualitative assessment of debriefs. And this was really guided by Restraint Reduction Network's post-incident debriefing guidance, which is available online. And in short, they distinguish 2 debrief stages. The first one is a post-incident support, and the second is post-incident learning. So the post-incident support is really very much about helping a person to regulate and to feel safe again. Learning is delayed for up to 72 hours. The reason for this 2-stage debrief is based on the science of the stress continuum, which acknowledges that incidents involving restrictive practice will increase stress for all involved. So not just the patient, but also the staff and the witnesses. And so there needs to be some time taken to recover from activated stress before access to the parts of the brain that enable reflection and learning can come back online. So if there is an initial debrief which asks patients or staff or witnesses to reflect or to learn from the incident, that is going to be very difficult for all involved because of the way that stress operates in the brain and the nervous system. So arguably without a 2-stage process, even very well thought through attempts to facilitate patient, staff and organisations to understand what's happened, reflect and learn are likely to be really ineffective. So we looked at to what extent were trusts reflecting these guidance. We found that 15 trusts had debriefing guidance in their policies which differentiated the 2 stages and that were essentially reflective of Restraint Reduction Network's guidance. There was variance in the levels of detail and the quality of these, but there were some well-considered examples. We found that 30 trusts, or 64%, did not differentiate between support and debrief with patients. So our recommendation here is that trusts implement a 2-stage debrief framework which makes reasonable adjustments for people with learning disabilities. So finally, let's think about the raising of concerns or complaints, drawing on Section 3 of the guidance, which states that use of force policies should include details of how patients, their families, carers and independent advocates can raise concerns about the use of force. So we found that 18 policies, so 38%, explained how patients, families or carers can raise a concern about the use of force. We found that 7 stated that there was a complaints process, but didn't say anything about what it was or how to go about making a complaint. We found that 14 trusts, or 29%, did not mention the complaint process in the policy at all, but we did find it somewhere else, like in the patient leaflet or the easy read information. And then we found 9 policies that said nothing at all about complaints or concerns around the use of force in their policy, and we couldn't find it in any other documentation like a patient leaflet. Raising a concern can be difficult due to the emotional load and the power imbalance of either being on a mental health ward or for families having a family member in a mental health ward. So the inclusion of information about how an advocate can support the making of a complaint or a concern is important. We found that 17% use of force or easy read policies included information about advocacy services in relation to raising complaints. The inclusion of this information does not have to be complicated So there's an example from one of the trusts on the right-hand side, which says if the person wants to formally raise a concern, they should be reminded of how to access the complaints system and independent advocacy services. People who need alternative support, alternative format, additional explanations should be offered this support to access and use the complaints process. So our final recommendation is that trusts provide accessible, specific, and local contact details for complaints and patient advocacy services so that patients have everything they need in order to raise a concern or a complaint. We address this a bit further in the second report around easy read information. We've made these 9, hopefully very straightforward recommendations, which give simple ways to improve policy compliance. Some of these are really easy to rectify, like just publishing the trust policy on the website. Others are more qualitative, requiring some consideration and reflection around language and process. Policies, at least in part, communicate and influence culture and practice. So tone, underlying assumptions, language, all have the potential to influence culture and practical expectations of the staff who read these policies. Therefore, it's important that commitments, such as to the minimisation of force and human rights, are communicated in ways that are unqualified. It's not just about what is said, but how it is said, and recognising that the how of the language influences to what extent a trust is compliant when we compare it against the requirements of Cheney's law. So the Cheney's law guidance is really clear when it says that a use of force policy sets out the organisation's commitment to minimising the use of force through the promotion of positive cultures, relationships, approaches that understand the trauma history and triggers of individuals and that will prevent escalation and any need to use force. And so the way that a policy is written contributes in some degree to achieving this. And lastly, we wanted to acknowledge that what is stated in a policy is not necessarily consistent with what happens in practice. It's possible that day-to-day practice might exceed the policy guidance found. It's also possible, of course, that some of the better policy guidance might not actually be being implemented in practice. However, all of that to say, we know from the evidence base that policies influence standards, expectations, and culture. So regardless of how policies actually are reflecting practice day to day, there is a significant benefit to having them comply with both the spirit and the letter of the law. Good, well-written policies are likely in the long run to influence culture and practice positively. Lastly, let me just finish by saying 2,000 people with learning disabilities and autistic people are detained in mental health wards in the UK every day. Despite numerous efforts from many directions, this figure doesn't seem to be changing. If it did, research and reports like this would be redundant. However, until this happens, we have a responsibility to ensure that people with learning disabilities who are detained on mental health wards experience equity. Hopefully, this report and these final recommendations help us to move incrementally in that direction. Thanks very much for your interest in this topic and in this research, and do feel free to get in touch with us if we can be of any help. There is a second report that follows a similar format but considers the easy read patient information on the use of force, how to write that, or if you already have something in place, how to improve it and review it.